I am so delighted to be here. I tend to walk around a little bit when I speak, and I hope you can still hear me. This is such a small
You can take the mic off the podium if you like.
Okay. Well, can I ask in the back, can you hear me all right? Yeah? Okay.
As long as you stand near the mic.
All right. I will. Then I won't be walking around, and I'll stand here next to the mic. What a delight to be here, and thank you, Dr. Nye, for being such a champion. I had a chance to read up a little bit about you and the impact that you had on this organization and on this important work, and to be talking about these issues when you began to talk about these issues really puts this organization in a position to deal with it in a way that is not common across the country. So I really applaud you and all of you. And Dr. Chen, I would like to just comment, I noticed Dr. Nye was teasing you earlier that you, being so prone to burnout in the past, choosing this position as president might have put you at an increased risk. And I'm actually going to challenge that. I don't think that's true. In fact, I think it's getting together in ways like this, talking about these issues, working together with colleagues who are like-minded. I think it's absolutely essential and actually an anecdote to the burnout that we face. So I'm going to talk a little bit about joy. And I thought before we talk later on, both Dr. Staggers and myself will give you some ideas on strategies that you can use to combat the feelings of burnout that many of us face on a daily basis. I thought it would be helpful to make sure we're all on the same page. I see that there are folks that are here from different walks of life, certainly different disciplines of practice. I am thrilled that we have a medical student here who can help to create some foundation for her colleagues at this early age, so that we can, begin in a very prophylactic way to look at this issue that is not only important to us, but it's absolutely critical to our patients, and it's absolutely critical to our profession and our society. So, start by sharing with you the words of a colleague of mine, Rachel Levine. She's at Hopkins, and she wrote this in an editorial that was published in 2016, April of 2016. So I'm just going to read to you an excerpt from this editorial. She's talking about her clinic day and one patient that she took care of. So, my first clinic appointment of the day runs late. After an initial greeting, my patient opens up about feeling overwhelmed. He is struggling to manage his home and work responsibilities. In his professional sphere, he is experiencing great pressure to be more productive, and he notes less energy and joy related to his work. Same time at home, he's often too tired to spend quality time with his family. He worries that he's not being supportive enough to his spouse, who is at home with their young children. We discuss strategies to create better balance in his life, and we never get a chance to even begin talking about his medical issues. The next day, I see my patient again, and this time he's walking the halls of the hospital. He looks harried, but he smiles and pauses to say to me, "Thanks for letting me vent yesterday," because this time, today, he's wearing his white coat, and he's an attending physician, and he's overseeing the care of his own patients. And I think this tells a story that strikes a nerve for all of us. It's a story that we share and perhaps have experienced in our own lives, just this general feeling of being overwhelmed. So when we, myself and my colleagues from the AMA, from the American College of Physicians, two organizations in which, under the auspices of which I do this work, what are we hearing from the people around us? What are we hearing from you in this room? And these are the words that are shared frankly, every day that we go out and talk to one another. The joy of practicing medicine feels gone. One physician actually said he hates being a doctor and can't wait to get out of it, this feeling of being trapped in this profession. Another very desperate one, I can't tell you how defeated I feel. The feeling of being punished for delivering good care is nerve-wracking. And then another that expresses that he's no longer a physician, but is actually the data manager, a data entry clerk, or a steno girl. I became a doctor to take care of patients, and now this particular one feels like it's become a typist. I want to put some faces to these words. I think we see those faces in this room because some of you have already expressed this sentiment. But here are another few faces that I would like to introduce to you. The first one is Gail Sullivan. She's a geriatrician over at University of Connecticut. And after 30 years of practice, she decided to give it up. She served as program director there, and for many years actually felt that her work was quite fulfilling. About 2 years after the implementation of the electronic health record system, she decided that she had had enough. Working in clinic for her had become so painful that she actually decided to leave her patients. And although the idea of leaving a practice and a life's work was so painful for her, she also could not accept the alternative, which was staying in what she did. So what she told us is that she, before the implementation of the electronic medical record system at her organization, she would end her day at approximately 6 or 6:30 p.m. That at the end, she would feel that she was rather fulfilled. When the electronic health record went into the system, she found herself working well into the evenings, 9:30 p.m., and still not feeling that she had delivered the care that she intended to deliver. This is Ben Crocker, also a general internist at MGH. And he's speaking now of these performance measurements. There are more performance measurement acronyms than any one of us can keep track of these days. And he feels that speaking of these performance measures, I have little things that have become the big things. And I fear that our role as healers, as comforters, and as listeners are being lost, right? This idea of putting the heart back into medicine. And in fact, in many cases, it seems like it's neither the heart nor the mind. It's more the fingertips and the clicker button these days for many of us. So those are two doctors, but there are also patients that are affected by this. And this is the word of a patient that's documented here. On a recent visit to a new doctor, I believe we made eye contact twice. Upon her arriving and leaving. And yet, I am much more able to receive advice from people I feel are thinking of me as a person rather than just the next patient. Okay. So here in this room, we feel it. We know that we and our colleagues are feeling those stressors, are often questioning what we are doing in our lives, in our profession, whether it's actually what we intended to do when we took the MCATs when we were all undergraduates. I mean, is this the life that we signed up for? It is making national headlines as well. So, and I think that's a good thing. I really think that's a good thing because I think it's important that we as a professional organization, as a profession, that we acknowledge what's going on, that it is recognized by society as well. And these are just 3 of the headlines that have been seen in recent times, and there are many, many more. So it's not only something that we're hearing, it's clearly being seen in the lay public as well. So before we talk about what burnout really is, let's talk a bit about what it is not, okay? Burnout is not the same as dissatisfaction, and it's not the same as disengagement. We could talk about how it may occur on a spectrum, and we could also, certainly I am not going to argue with you that we should, I would agree, let me say, that we absolutely should pay a lot of attention to dissatisfaction. And we should definitely pay attention to disengagement as well. But we have a special need to identify burnout for the reasons that I'll mention. So what is dissatisfaction? You know, we're dissatisfied with a lot of things, aren't we? We don't like certain things. We may not like breakfast. We may not like our cup of coffee, but we don't like things when we are dissatisfied. Disengagement is something a little bit different, and that I think is best categorized by this: I don't want to do this. Okay? That's what disengagement is. Burnout, however, is something even more so, and that is I can't do it. So it's not that I don't like it. It's not that I don't want to do it. It's that I really can't do it. There's something that's required of me that I just simply do not have the energy, the emotional reserve to do at this point. And that is something fundamental to burnout. Makes it slightly different, importantly different than the others. So the three components of burnout include emotional exhaustion. You know what that is. You know when you just, again, feel like you can't take on the next challenge that's there. One thing that's very critical for us as we interact with our patients is the cynicism and the depersonalization that occurs in the setting of burnout. And then a long range poison in us is this sense, this diminished sense of personal accomplishment. So those three components are generally accepted as the criteria for burnout. So there are lots of factors that lead to burnout, and we will talk about them more this morning in greater detail. Certainly this has a role, okay? If you have excessive workload, right? Just too much for you to do in a day, that is potentially a cause of burnout. But I want to tell you that it's not enough. There are many folks who work very hard. Dr. Chen, in all those responsibilities, you've worked really, really hard. They need not have led to burnout. So it's not just a matter of workload. And so then when you take the counter, look at that, it's not about doctors not wanting to work hard. Okay? And that's something that we need to be very careful about when we're engaging in these conversations, not just with our colleagues, but with outside society. This isn't about doctors not wanting to work hard. This is not about doctors being lazy. It's not about the next generation, millennials, you know, just wanting something different out of life. That is not what it's about. It does have to do with workload, but it's not exclusively or uniquely about workload. There's a clear role of work-life balance issues in the etiology of burnout, okay? That Dr. Marcus Welby of yesteryear, that which we idolize, I mean, it's not even possible. And I wish I could remember, there was an analysis done on Dr. Welby and what it would have taken to actually conduct a practice the way that Dr. Welby, you know, actually conducted that practice. And he literally would, you know, in order to even sustain a practice, there was absolutely, like, it was negative sleep balance. Like, you could not do what he did. So work-life balance is important. And we need to find a way to not just be doctor all the time, because we have to care for ourselves, find rejuvenation in the relationships that are important to us and the activities that are important to us, so that then we can turn around and be healers to our patients as well. I think this is really important. And in my own personal life, in my own personal professional life, and personal life, I think control is absolutely key. You know, feeling that we had a role in that decision-making process, that I think one of the worst situations for a physician or any human to be in is the sense that you're trapped, that you have no choices, that you cannot effect change. And like what was said by one of our colleagues here this morning, we're smart people. You know, some of us are brilliant people. We've gone through many years of education and training, and then at the end of it all, to find yourself in a place where you have no control can be absolutely devastating. Okay? So this and other factors, and again, we'll talk about the granular aspects later this morning, lead to the burnout process. I'm a leader in my organization. In my work life, I'm chair of medicine at Cook County Health and Hospital System. I have leadership roles in the American College of Physicians that I take very seriously. It's very important to me. I think as leaders, and I heard that there are several leaders in this room that help affect policy and practices within their organizations, it's absolutely critical that we look at the organizational response to the patient and to our physician's situation. So there are lots of external factors, right? More acronyms, MACRA, PQRS, et cetera, lots of mandates, often unfunded mandates for us to comply with different quality metric reportings, et cetera, right? What the organization often does in response to these external mandates is to impose upon our physicians new practices and policies, new demands, right, as an organization. So yesterday morning was our Department of Medicine faculty meeting that I lead as chair. And yesterday morning, we were showing dashboards of meaningful use compliance and history and physical completion rates and discharge summary completion and flu shots vaccination rates from last year to motivate our physicians to do what they need to do next year. All of these things are important, except as a leader, what I need to stop and ask myself is, how can I make it easy for my physicians to comply with these things? And more importantly, how can I help my physicians by creating a system around my physicians of support to comply with these mandates? So it's a different topic, it's a different lecture for a different day, but one I actually enjoy giving a great deal is how leaders should organize the work for their physicians. But what do physicians, each of us as practitioners, what do we feel? We feel like our organization often does not support us because we feel like we're being asked to do much by people who just simply, they don't do what I do. And so they don't understand my job. It's easy for them to tell me to click off more boxes, etc., but they don't do it. We as physicians, we feel like cogs in the wheel. We don't feel valued. We're just receiving negative feedback. And of course, at the end of the day, the job is absolutely exhausting. So how bad is it out there? Well, we're all kind of had it up to here, right? So it's getting worse. That we know. About 45% in 2011 reported, this is all physicians that were surveyed through Science Daily, that about 45% of physicians reported the symptoms of burnout. In 2014, the number rose to 54%. Now, if you do the calendar math on that, that is rising at an alarming rate. And it's just simply not sustainable if we want to care for our profession.
Is that self-reported? Or
this is self-reported.
Or is there like a questionnaire tool that's been validated to assess?
We'll talk about that later. There's a number of studies that have used a variety of tools, and actually, I think I might even show you one of the tools later in my slides, but certainly I can refer you to them later. Yeah. So I'm going to leave this slide up for a little while because people love to look at this slide. People love to see where they're at and where their profession is compared to everybody else, right? I'm not sure, yeah, we're all competitive. What's that?
It's the lowest rate.
Okay, so this is what percentage of physicians are feeling burnt out, okay? And this is on by survey using these criteria as for burnout, right? Loss of enthusiasm for work, feelings of cynicism, low sense of personal accomplishment. And this is what Wilkins found. Okay.
Could you share the source for that?
Yeah, certainly. Yeah. Emergency medicine at the top, critical care. I know we have family practitioners in this room. I know we have OB-GYNs in this room. I and others are internists.
And hospitalists?
This is not separated out.
It just seems like that group is highly affected by this.
Yeah, this doesn't have that separated out. They would be captured within internal medicine in this group. Yeah.
I know I should have gone into dermatology, but why? Where would they be on here?
Oh, there, I'm on rheumatology.
Yeah.
All right, talk to me.
Right here, here at the bottom. Can you see through?
Yeah, I got it. I'm sorry.
Okay.
Sorry.
All right. Now, while those of us who are primary care providers up here are thinking, gosh, we should have gone into dermatology. I'm going to push back on that for just a minute. Because certainly our ED colleagues are more burnt out. But these guys are still 30% burnt out, right? I mean, it's still alarming. Yeah, it's still alarming at this rate. But we're competitive by nature, so we want to be better than the guy next to us, I suppose. Okay. You know, when the electronic medical record was really rolling out and being mandated for use, there was significant concern, I'm sure you have heard it as well, that we were going to push our more senior physicians into retirement, right? That they would simply dealing with the medical record is going to be too much for that subset of physicians who could not retrain themselves to use that tool. The electronic medical record is not the only cause of burnout, okay? And what we see that I think is alarming, is well captured among hospitalists actually, is that burnout is occurring at a very early point in their career. Okay, so this is 33% of folks that were less than 1 year into their practice were feeling more stress than they did 3 years ago. And this is just stress on this survey. It's not the entire spectrum of burnout, but it's not just our more senior physicians. It's even at an early age, okay, an early level of experience. And in fact, studies, one done by Tate Shanafeld out of Mayo, showed that feelings of burnout begin as early as the second year of medical school. And then when students begin to feel that burnt out students, just like burnt out practicing physicians later, are at a much higher risk for professionalism breaches as well. Okay? So it's starting very early. So there's more to it, I think, than even we've uncovered at this point. So I tried to pull apart this idea that being disengaged is not the same thing as being burned out. Being dissatisfied is not the same thing as being burned out. And stress is one component of burnout, but it's not the only component of burnout. It's more complicated than that, but I did want to share this with you because as a leader, an organizational leader, we're all leaders, but as an organizational leader, a department leader, I was rather surprised by the data that shows that even our individuals that are engaged with us in the processes of patient care, they're still feeling a lot of stress, okay? So it's not that it's easy to pick up on what the phenotype is of a stressed out physician. They're not just the disengaged ones, the ones that are sort of overtly nasty at times to their colleagues and potentially to their patients. It also affects our engaged physicians. We're talking about it now in the US, but it is a problem that is universal. And I think this data is also interesting about the stress that our colleagues around the world are feeling. So in red up here are individuals who are saying that their work as a primary care physician is extremely or very stressful, okay? So our UK colleagues, I don't know if this is projecting well enough for you to see, but you see the red on top is extremely or very stressful job as a PCP. In the middle here is in black, self-reported as somewhat stressful, and then in white, not too stressful at all. Okay? So here in the US, there are only about 12% of primary care providers that are saying it's not so stressful, 43% that are saying it's extremely stressful or very stressful, okay? And so here again, you can see how we stack up against our colleagues around the world. So Don Berwick and the IHI expounded this idea of the triple aim, right, where our primary goal is here, better quality care, better outcomes for our patients. And to achieve that primary goal, there were two other important goals, and that included keeping costs low and an improved patient experience as well. So my colleague at the AMA, Krasinski, with some others, expanded this concept to the quadruple aim. That not only should we be striving for better quality outcomes for our patients at a lower cost, aligned with a better patient experience, but we should also be very much concerned about physician wellness. And as we talk through this morning, I hope I can show you good reason for you to believe that physician wellness is critical to better outcomes for patients. It's actually a role here in lower costs for our healthcare system, and certainly for improved patient experience as well. So these goals are absolutely intertwined. So as we talk about the triple aim, I would challenge this group, and to take it back home to the others that you speak with, we should be talking the quadruple aim. So burnout may cost US healthcare. Again, a number of studies that have been done that have in general shown that physician burnout is associated with more referrals made by providers, an increased degree of testing, that it is leading to fewer primary care providers across our country. There are actually higher rates of self-reported errors among individuals who also self-report as burnt out. And for our patients, there's longer post-discharge recovery time as well when the discharge was made, when the hospitalist often describes himself or herself as burnt out. Burnout is costing organizations as well. It's associated with an increased malpractice risk, lower productivity in the setting of burnout. More providers are moving to part-time status as a way to counteract the feelings of burnout that they're dealing with. And it leads to an increased MD as well as ancillary supportive staff turnover. Okay? And if you think about the cost to an organization to replace a provider, even a primary care provider, that cost of that turnover approaches $250,000. Okay, so there's a significant cost there. And then burnout affects patients. Physician burnout is associated with decreased patient adherence to your recommendations, including medication. It's associated with less empathy, lower patient satisfaction rates have been reported, and more likelihood that your patient is going to select a different provider for his or her care. And finally, burnout costs physicians a great deal as well. So we're feeling this in our personal lives with increased disruptive behaviors in those patients, in those physicians that we might see at the licensing board, higher rates of divorce, of disease, substance abuse, okay, and suicide rates that are higher, significantly higher than the general population. So burned out clinicians have a 16% decrease in patient satisfaction scores, 11% increase in medical errors in burnt out surgeons. Costs, as I said, hundreds of thousands to replace. While satisfied clinicians, okay, they tend to work longer over their lifespan. They retire later. They're more productive. They have better patient satisfaction ratings, and they have higher quality metrics. So the goal of finding ourselves in this state of being a satisfied clinician, and the role of making our colleagues also find themselves, helping them be more satisfied, is very important to U.S. healthcare. I suspect that many of you know this painting, a late Victorian painting that hangs in many doctors' offices. I remember seeing it in my family physician's office many years ago when I used to go as a child. What do you see in that photo? Why do you say that?
It's really focused on the greater totality of this, the big picture landscape that this person is tending to, with a real deep thought being projected.
I don't see a computer there.
Yeah.
What else? What else do you see?
It's very personal. It's getting a whole concerned, connected to the situation. You can see the whole family's exhausted. The mother's collapsed over there. He's at the bedside, just giving every bit of attention and compassion to his kid, whether or not she's having it. Back then, they didn't have cures. People get silly.
Could I ask you to speak up, or could you repeat the sense of question? Can't hear back.
Oh, I'm sorry. He was saying it looks like the entire family is broken, and he's there giving every last ounce of compassion and care to this girl, whether it's hopeless or not. He's giving his all.
So it comments about being present, being in the home, fully attentive to the patient. The fact that there's no computer there.
Well, I think back in those days, physicians actually knew not just the patient, but the whole family and the family circumstances. Now, most of the time, the patient walks in, you don't know much about that patient. Even family practitioners who practiced 20 years ago before electronic medical records, it's not the same as back in those days.
He's looking at the patient, he's studying the patient, looking for signs, and you can see with the elbow, he's thinking about the patient as he looks at the patient. And so often, you know, with computers, docs don't actually examine the patient in detail.
It's really a beautiful depiction. I'm sorry, one more.
Yeah, I mean, he's giving his all from his brain, but, you know, as a holistic computer, you can take the hand, massage the hand, and, you know, whatever. So it's not all positive, I think.
Looks like he's listening, though.
Looks like he's listening. So here's what we look like these days, right? And when you juxtapose this on the previous image, whether it's all positive or not, I mean, it's really profoundly different. And one has to wonder if you're able to give that degree of attention the way things are. So this year,
Can I say one more thing?
Please.
Malpractice,
yeah,
right?
yeah,
I mean, when you enter all this information in the computer, most of the time you're thinking, I want to make sure that I get everything in here in case something happens. I don't want the lawyer knocking at my door saying that, why didn't you do this? Why didn't you do that? Back then, I mean, even now, other than the U.S., everywhere else in the world, malpractice is unheard of.
Any other comments on that? You know, that is such a timely comment for me personally. It was just maybe Thursday or Wednesday of this week, I got an email from a member of in my Northern Illinois chapter of the American College of Physicians, where I serve as governor. He's a member of the ACP. He serves on the state disciplinary board, so has had some of the experiences, I think, that you've had, Dr. Nye. And he was sharing with me, he's at the latter part of his career. He was sharing with me that over the last 2 years, he has been involved in his first malpractice process. And he is a general internist. In our state, he's one of the rare ones, actually, general internists that cases actually go to trial. Most often these are settled out. I think in our state about 3% actually go to trial. And his was, in fact, one of those that went to trial. And at the end of the process, the jury ruled in his favor. Having said that, he was talking to me about how devastating that process has been for him. Now, he's been involved in that, at the licensing board levels, with evaluating colleagues that have gone through processes like that. But he was saying that we need to talk about this more as the American College of Physicians in Northern Illinois. So he approached me because he wanted to help create more of a discussion about that. But I think that's absolutely true, and I don't think we want to talk about it yet. Like, we're getting to the point of talking about burnout, but I think this is still yet a taboo topic, and we need to talk about it because it has profound effects on the way that we practice. The issue of physician suicide is complex. And I don't mean to suggest in any way that it's about the electronic health record. Okay? It's a very complex issue. But we can't deny the fact that our colleagues have profound rates of suicide. Okay? And that there's, one a day, an average of 400 US doctors are committing suicide every year. So we wanted to, in this first half hour, just give you an idea of what the present state of burnout is. We're going to talk a little bit more as the morning develops on strategies to combat that, both personally and situationally, which I think is important as well. So I hope to just begin the conversation with you now. Talking about some of what we can do very pragmatically to combat the burnout that we are feeling in our practice. I'm very grateful and fascinated by the material that Dr. Standers presented, and much of what we can do as individuals or in groups to modulate our own stress and self-health strategies. This next conversation is going to be very different. It's going to be talking about what our organization can do for us, or practices that we can put into effect in our workplaces that will help also offload the stress and the drivers into burnout. What we know from a number of different bodies of work that has been done is that physicians want to provide high quality care. And in fact, the provision of high quality care is a significant driver of our professional satisfaction. That's why we entered this job. None of us wants to do a bad job, and giving us an opportunity to do better work for our patients actually in return provides us more satisfaction. And another concept that I introduced earlier and Dr. Sanders spoke about as well is that control is absolutely key. It's this feeling of being stuck without options and without control that is particularly damaging to our satisfaction. I'm going to focus on quality and control and strategies that we can utilize in our practice to regain control over those. So this is work and actually some conversation that I had with Mark Linzer. Mark Linzer is a general internist, the chief of general internal medicine in Wisconsin, and does and has been doing for decades a good deal of work around physician burnout, frankly, before it was a popular topic in medical organizations. Now, this is, and I would love to hear later Dr. Stagger's comment on this, but how Dr. Linzer characterizes it is that the mindfulness and resilience work and stress reduction work that we do within ourselves is particularly useful for low levels of burnout. So I'm challenged by that based on what I just heard from you earlier. So we can have a conversation if we want about that. But he feels that system changes are really the way to counteract greater levels rather of burnout. So I'm going to focus on those system changes. And what I'm presenting to you today is a menu of changes that you may be able to implement in your practice to deal with the etiology of burnout, again, in your practices. And this is based on work that was done by my colleague at the AMA, Chris Zinsky, and her colleagues, through an ABIM Foundation grant, decided to look at several high-functioning practices around the country and learn from them what it is that drove satisfaction in that practice, and also look at other measures of the care they provided, including quality. The investigators on that study, and these are the locations of the practices that they visited, most of them in person, a couple of them web-based visits, but you can see that they were around the country. I'll also tell you that these practices included small private practices. They included federally qualified health center located practices. They were all primary care practices, but were both internal medicine and family medicine practices. They included ones that were in academic centers. So it really was quite representative of the work that we do. Okay, and their goal was to find ways and strategies that we can create work that is more enjoyable so that we can continue doing this as a life profession. Giving you an idea of where these were located and the names of the practices involved in this study. What they found was 4 areas that redesign within can create more likelihood for physician satisfaction. And that included optimizing workflow, distributing tasks differently among the individuals working in that practice, some changes to physical space, and also using technology differently. Okay? The challenges that they identified included very chaotic visits. So that when patients came in, there were so many different needs that the patients had, both preventative care needs as well as acute care needs. They noticed that in several practices, or the practices reported prior to certain interventions, there was significant lack of support for the physician from the staff that surrounded him or her. There was not enough time to do all the documentation that was necessary to achieve the billing functions of that role. The electronic health record actually was sending more work to the physician more so than had ever been before they implemented the electronic medical record. Overall, the teams were functioning poorly. So these were the major challenges that were found. And through a number of interventions, and not every practice employed each of these interventions, but this is just to give you a sample of what this group of interventions might actually save you in a day, employing certain strategies like pre-visit labs, prescription management, and I'll describe that more in a bit, expanded rooming and discharge protocols utilizing other staff in your practice, optimizing the physical space and where the physician sits, where the MA or the nurse sits, utilizing team documentation approaches, utilizing automatic logins, sort of RFID logins, for example, and paper and verbal order entry could save a practice, an individual physician, 3 hours per day. Okay? Hard to believe, perhaps, but I'm going to show you how the math works out as we go through. It requires, though, first and foremost, that doctors cannot do it alone. Okay? You must use the other staff members that you work with that are part of your team. And so primary care team members have a number of different functions here. And in order, you have to re-visualize the doctor and the team as partners in this process. Perhaps the doctor taking a leadership role, but absolutely cannot do it alone. If you think about the way we work in an underutilized production environment. We are not utilizing our supporting staff to their highest skill level, to the top of their license, so to speak. Okay? What we want to do is to create a situation where our doctors are finding ultimate joy, but also that our supporting staff members, our MAs, our social workers, our nurses that we work with are also achieving that same joy. And we find that these strategies actually help all members of the care team find greater personal satisfaction. So this is kind of where we're at right now. So I'm going to try here over the next few minutes to give you some of the wheels that I think will help us move a little faster and certainly move a little smarter as well. So one challenge is the vast amount of time that we spend documenting care. So ways that we can address this challenge include team documentation and using an assistant to enter orders into the electronic medical record when necessary. On Thursday, I had a visit from a graduate of mine. I ran the residency training program at my institution for many years, and he graduated in 2015, did a one-year chief medical residency with us, and then just has been gone from my department just for a few months, but he came back to visit on Thursday. And he's now working as a hospitalist, and he was saying how, it's a good job, meaning that the hours are manageable, the workload isn't much, but he didn't feel fulfilled in that job. And in the midst of our conversation, he spoke about the note and how when he comes on for his 1 week on, how he has to re-interview and obtain all the information from the patient. So I just sort of asked him, like, well, don't you do a handoff from the previous physician that was caring for the patient? And he said, oh, no. And I said, well, do you read the note? And he said, notes have nothing to do with what's going on with the patient. And I think that, many of us would share that sentiment because notes have, and he actually referred to it as a billing note. The note's a billing note. It doesn't really tell you what's going on with the patient. Okay? And so we get through it. It's like dropping a super bill. It's not about communicating to our colleagues or to ourselves when we see this patient return to our office 3 months later. It's more about just getting what's done for, getting what we need to get done for them. So this is personal communication with a nurse who works with this very brilliant physician. And she says that the physician who I work with is recognized by peers for his brilliance, compassion, dedication. He has a skilled way of eliciting information from patients, which helps him develop a diagnosis and treatment plan. But watching him being drawn away from that for tedious, compulsive, non-gratifying tasking is painful at best. And this is coming from the nurse. So a lot to talk about with the electronic medical record. It's too much time per task. You know, it's clerical. It's a major driver of dissatisfaction. It decreases the face-to-face time. In one particular study, 20% of a physician's workday was spent in actual face-to-face time with the patient. Okay, and even during that 20% of time, he or she was distracted by the computer to decide. The electronic health record, especially computer order entry, was a significant driver to burnout. In this Mayo Clinic article, 44% were dissatisfied with the electronic health record. 63% felt it actually made their work less efficient. Nearly half felt they were spending too much time on clerical tasks, and a significant number felt that it did not improve care. So it was associated with burnout in this group. 59% was the use of electronic health record and computerized order. We know it, we feel it, higher rates of burnout around the country. It's not all about the health record and electronic health record, but we'll get into this a little bit more. If you think about it, James Madara, who's the president of the AMA, at our 2016 AMA annual meeting, said American physicians have become the most expensive data entry workforce on the face of the planet. Right? Very, very true. And on average day, 4,000 clicks, okay? In the emergency room, a 10-hour shift, according to this study in the American Journal of Internal Emergency Medicine, as well as the Journal of Medical Informatics. In the ER, 10-hour shift, 44% of it was spent in data entry. There were 4,000 clicks documented. 28% of the time was actually spent face-to-face in front of the patient. For PCPs, it's not too dissimilar. 11-hour workday, 50% was on the computer, and that includes inbox management and computerized order entry. 20% of it was with the patient, and in this study, 1/3 of that 20% was in screen use. When looking here, this is done in Wisconsin again in family medicine. We found when looking at when the electronic health record was being accessed, that 32 hours of work per month were being done after work. Okay, so 32 hours, that's basically a full week's worth of work almost. So we're taking that work home with us significantly. I love this slide. It's depressing, but Epic, our Saturday nights belong to Epic. So, isn't it sad? So here's what's happening. The blue is on a weekday. The orange here is on a weekend. And again, when you look at when we are accessing Epic, look at that. Huh? How many of us are doing it? Here's, if you can't see that too well from where you're sitting, that's about 6 p.m. right here. Okay? So it drops off around 6, 7, 8 o'clock. Many of us are running home to be with the kids, right? Put the kids to bed. it blips up a little bit, and look at what we're doing on the weekends. I mean, that should be time where we're spending with our significant others, our partners, and we're actually spending it with Epic. Physician practices are spending not just time, and time is money, spending a great deal of money on reporting of the measures that we're mandated to report. So $15.4 billion annually to report quality. So that's not why I went into medicine. It wasn't about paperwork and regulations, but clearly you wouldn't blame me if I feel like that captures my job accurately right now. So again, our challenge is the time spent documenting care and what are the innovations that can be used. So one of the practices that was studied was at the Cleveland Clinic, and this is Dr. Kevin Hopkins. And what he utilized in his practice is a team documentation approach. And again, as I talk for the next few minutes, I'm trying to provide you a menu of different options. You may not choose to use any particular one. You certainly may not use all of them simultaneously, but they're just things for you to think about. Does this fit into your practice? Can you implement them? And what kind of difference can you expect as a result? So Dr. Hopkins says he used to spend an hour or two in the evening after his family went to bed completing charts for the day. Very common experience for most of us. After implementing a team documentation protocol in his clinic, he doesn't log on from home anymore. And he states he's forgotten how to use it. So what does that look like at the Cleveland Clinic for Dr. Hopkins? It means that there's a pre-visit agenda that is driven by the nurse, okay? And that pre-visit agenda, before Dr. Hopkins even enters that room, medication reconciliation is completed. The agenda for the visit is established at that time by the nurse. It could be an MA in your situation. And parts of the HPI are already obtained from the patient and also documented. So a rooming protocol that previously may have been 1 to 2 minutes long has been expanded now to be closer to 6 minutes long in the case of this clinic. So it's a little bit more on the MA. Then the doctor comes in with the nurse and they do a number of things together that visit. Okay? After that visit, the nurse remains in that room. And the nurse reviews a visit summary. So again, some teach back there done by the nurse and does some additional health coaching. And by that time, the doctor has gone on to the next patient. Okay? What you see here is the doctor looking at the patient. What you see here is the nurse or the MA who is scribing while the physician is working.
The downside to this is that people in private practice, in small practices, this gets very, very expensive. So this actually pushes people in the community into corporate medicine, which is the last place that anybody wants to be.
So I'm going to talk about, we'll talk about some of the costs associated in it. We'll get to that because that's an immediate concern. Okay, so what this meant for Dr. Hopkins in his practice is that he needed to employ 2 MAs, nurse MA, where in my part of the country, MAs are much less expensive than a nursing trained individual, 2 MAs to 1 MD, okay? Based on the calculations in that clinic, 2 patients per day additionally seen would cover that cost. So when he decided to hire that additional MA, his expectation was that he would have to increase, or his goal was to increase the visits per day from 21 to 28. Okay? So a 30% increase in revenue is actually what he found. And he found that everybody was having more fun. So this is important because he was able to focus on the patient And importantly, the MAs were having more fun as well. They felt much more involved in the care of that patient. They had a real purpose. They were working to the top of their license as well, and it was a better opportunity for everyone in that practice. So there's a number of studies and articles that have looked at the role of scribes in a physician practice. A couple things we know is that the patient-physician interaction improves. That's no surprise to most of us. If we don't have to look at the computer and type, of course the patient is going to feel that he or she is being conserved to better. But the documentation is better and certainly not worse when it's put in by a scribe. So there's some of us that might feel that we can document it better than a scribe. Would the scribe actually not capture important elements of that interaction and leave that out from the medical record? We just don't find that that's true. So the scribes had maintained the same level of documentation as the physicians or improved the level of documentation. So again, the MAs are more fully engaged in patient care and they're happier as well. Yeah, question?
Does a scribe need to be trained like a nurse or a physician assistant? Can they have a more brief, obviously reciprocity, but sufficient training?
So scribes are scribes and they take different forms and different practices. I was at a wedding in Wisconsin for a family friend where I met a physician whose son, his unemployed son, serves as his scribe. I mean, and he has no medical training. So that's a private practice situation. We certainly have an opportunity to use MAs that are skilled and can perform some greater rooming functions. If you have an MA that can scribe for you, they can also bring the patient into the room, do the vitals, do some of that pre-visit work in terms of medication reconciliation as well, that another untrained scribe might not be able to do. Yeah.
Do you know what electronic health record they're using at Cleveland Clinic?
I'm pretty sure it's Epic. Yeah, I'm pretty sure it's Epic. Yes. Why do you ask?
Well, just, I mean, I've toyed with doing some of this in my own personal practice. And, I'm on EMVs, which is another electronic health record. And I like it because I can tweak the templates of how I document. But every time I do that, I have to train my staff about where I put things. And so, it sounds nice as a concept, but to actually logistically be able to do that, I think it's going to be a lot of work and training because my medical assistant knows certain parts of the EHR really, really well, more than I do. I know the medical care documentation probably the best in the office. And so if we're going to be co-documenting together, having resources or training the staff to be able to do that, I think is going to be really important.
Yeah, and that's an important point. There's always upfront training cost in this one. There always is. Your MA or your nurse is going to be working with you closely, and you're going to have to invest some time figuring out with him or her what it is that person is going to document, how you like things documented to meet the professional goals of your practice. Yeah.
Issues about either confidentiality or patients opening up about certain issues that they don't want to be present for.
So in terms of HIPAA issues, there really aren't any in this scenario because these are individuals that would be operating under the same HIPAA practices and as part of your practice, as part of your office. In terms of how do patients feel about it, what we know is that patients actually leave more satisfied. I don't know that I've seen data specifically asking patients whether they withheld information because there was a third party in the room. I haven't seen that data. I don't know if that exists. But overall, patients are more satisfied. And I think they kind of forget that person is there, at least for that window that the doctor is in there, because the doctor is completely focused on that patient. It's used in other practices as well. At Ellen Clinic, they do the same with collaborative care. And this is, again, a very team-based model where the MA has a significant role in the pre-doctor visit as well as the post-doctor visit. And here, the patient satisfaction and the provider satisfaction also went up. And there was less electronic health record use by the physician, which again was a driver of patient satisfaction. Okay? So we don't like the EHR. It looks like our patients don't care for it much either. Okay? So in that practice, in Dr. James' practice at Bellin Health, they turned the EHR into an ally rather than an adversary. The MAs are doing much of the computer work, including the order entry, the refills, care gap closures, team documentation, and the physicians are focused on the patient. In terms of the, yes?
I, in the beginning in Epic, I was having my medical assistant put in a lot of the orders,
Yes.
and I got dinged for it because I'm supposed to put the orders in meaningful use. So, sure how that would work. It wouldn't work for my sector because I get dinged for not.
Can I ask you who dinged you? What do you mean you were dinged? Your own organization?
Yeah, the organization, because the doctors are supposed to be.
Did you have a comment to that?
I have to approve the orders.
Yeah, I have to.
That's happening. It's not correct. She
Yeah.
can't approve them, but she can.
I don't, and that's why I asked you, who deemed you, because maybe that's based on a lack of understanding, and it must be at the organizational level. But they can absolutely enter those for you, and in fact, for other meaningful use, like enrolling patients into the patient portal and even sending of secure messages, that can be done by others in your office as well, or providing, discharge information can be done by others in your office. So I feel like that was based on some lack of understanding, perhaps, of the organization.
But I guess maybe Eric has the point, who signs it. And so it's already entered by somebody else.
I think you're right, it might be an organizational issue because we're on the same system. And my MA would say, well, I'm not allowed to put orders in. I said, who said? They told me so. I said, no, that's not true. You're not putting the order in. You're just typing it in. I have to sign it. Without my signature, it's not a valid order, period.
Yeah.
So I was able to convince her that she could put the orders in because you're wasting my time. Right?
Much of this is based on individual and organizational, misunderstanding. I work in a highly unionized environment, and maybe some of you do as well. And everyone in my institution is unionized, from doctors to the MAs and everyone. So there's some of those restrictions are not because they really can't. It's not because they can't from a meaningful use perspective, but it may, up until now, fall outside of their job description. And you need to challenge that. You challenge it in the appropriate way for your institution, but I would challenge you to challenge that, because these are important ways that they can help you do the job. Yeah.
Just sort of an understanding, do they log in as you and then document as you, as your scribe?
Not.
They log in separately and they're doing the assessment as the MA, and then you supervise that and add to it in your notes?
That is correct. It's the latter. So, wait. There can be dual logins to the same patient chart. So they would finish parts of that note and part of the documentation of that visit, and then you would input your parts of
And
that
you would
visit.
click the final submission.
You would click the final submission.
Great.
And that's how we do it. We have Cerner, and that's how we use it in our practice. I believe that's also the way many Epic practices. There's so many EHRs, so I don't know exactly the functionality of your particular EHR.
Yeah, the way Epic works is that my MA, for example, does the drug review, medication review, and does the vitals, et cetera, when you open those sections, you see that this information was reviewed by so-and-so MA. Well, there's a box that says reviewed. When you click on it, the name changes to your name.
Right.
So that means you reviewed this.
And then that's the check.
Right. So you're double checking what the MA has done, and you're essentially confirming that she did the right thing, especially with the list of medication, because sometimes they forget or there's a missing medication that we end up adding in later.
Back, please.
So there's other really robust options. So we're on Epic, and we have a chronic care method, RMAs, and the information, diet, exercise, home monitoring, and we changed the font color. So when you look at that note, the green color is what the MA is documented, the black is silver. So there's a lot of ways to use your EMR. You can think about font color, italics, bolding, and you can create a whole template. So we have a whole chronic care template. They document the note. Everybody takes 12 minutes, takes me about 10 minutes to see the patient. And the whole 12 minutes she's in there, I'm working on my investment. So think of the ways that it works like Outlook or Word, that you can change font, change size, change color, and you can create a whole message to share.
Thank you.
I don't want us to get too bogged down in the details of BHR. I'm a psychiatrist. I actually have never had to do practice totally in EHR. I did it somewhat in a county job I had for about 5 years. But what I want to say is that regulation varies from state to state, what AAs can do and or what RNs can do, and what the physician can or has to do. There are pitfalls. I suspect what this points out is that we need some kind of forum, some kind of other event that helps people negotiate some of these rules, because some of them are also a loss prevention problem for the malpractice and for your own protection of your licensure. So with that said, and the differences between states, and I'm not sure how conversant you are with California law, and I'm not that conversant with it either when it comes to being applied to something like primary care. Where I just wanted us to be sure that we could finish this without getting too locked into details that I'm not sure we've got even the right experts here to answer.
What a fantastic idea for another more hands-on session for as an organization to go through. So let me continue to, yes.
I just want to add on to Dr. Nye's comment. There's some discussion here about being told you have to do some things, whether it's a hospital, whether it's your MA. That's the kind of thing that we really encourage you to contact the medical association. That's the information we can provide you. We've done that for years. Call us when you have a question and let us tell you so you can go talk to whomever's told you you have to do that with information to challenge them. Please.
So here's just to provide some of the results on the quality metrics that they saw at Guiding Clinic. You see the baseline and listed first, and then their goals followed by the actuals. So this is using that team-based model, offloading some of this work to the MA or the nurse to do. I'm using protocols such as standing orders, and again, you have to point well taken. California law may be very different than Illinois law or others that I'm more familiar with, but using some of these strategies, quality did not suffer, okay? And so these are some of the results for the screening tests. How satisfied were individuals in that role, and this is including physicians and other staff, before the team-based documentation intervention? Very dissatisfied in 42% of staff, after 0%. And again, I'm just pointing out that this isn't just physicians that are responding to this. This is the entire team that at the end of a team documentation effort feel better about their work. At University of Utah Redstone, similar improvements in terms of using that team-based approach, better rates of immunization, better cancer screening rates, better diabetic management metrics as well, increased productivity, and patients as well as physicians were more satisfied along with their other staff members. Okay? Doctors are feeling like they can actually look at their patients, they can talk to them, there's more of a human connection, they're reconnecting, their satisfaction numbers are up, their quality metrics have improved, and the nurses are contributing more. And at the end of the day, physicians can go home and actually have time to spend with their families as well. So Clinic A here, to provide a little bit of that business model, Clinic A has a 1-to-1 ratio of MAs and MDs. Now, in my own system that I work in, and we're doing some pilot work to introduce something very different, but our existing system assigns 0.8 MAs to every 1 FTE doctor. Okay, so we don't have even 1 MA per doctor. We're on any given day sharing MAs. But in this business case, you'll see if with a 1-to-1, 4 MDs at $250 each, $1 million, 4 MAs at $50 each, $200,000, for a total of $1.2 million. In Clinic B, the relationship was 3-to-1. So in this case, they employed 2 MDs at $500,000 and 6 MAs, again at $50K each for $300,000, and it was an $800,000 total. Okay. So in each of those cases, they were able to see 4,000 patients per year, because the work of that patient care was shared between the physician and the MAs in that practice. So in each of those cases, it's not that you're adding more costs, you're also seeing more patients. And that is the key. So when you're making that cost argument, it's a losing argument if all you're doing is getting more help. The idea is that you're getting more help and that your patient care productivity will also increase. So whether it's a fee-for-service model, and as we transition to alternative payment models, etc., it's when you're looking at the outcome, in both cases, you can make a financial argument. We have some tools on our website that I'll introduce you to help you make that argument. So another challenge that some of these practices that we studied experienced were these chaotic visits, agendas that were just too long. So what we started, some of the practices included was pre-visit planning, pre-appointment labs, and systematic prescription management. So I'm going to talk about those strategies. And we know that some of the major time wasters in the practice include the time that we spend refilling prescriptions outside of our visit. All the faxes that come in from Walgreens, CVS, Rite Aid, that you have to spend time, your nurses spend time on, and then you have to also sometimes spend time on signing off. If we're refilling prescriptions more than every, or if we're refilling them every 3 months rather than on a yearly basis, that's incredible time waster. Ordering labs between visits, so when a patient comes in at that visit, you order a lab. Patient might come in 2 weeks later, get that lab done, and then you have the result and you need to act on that result, and that takes time, right? You need to receive the result, review the result, you need to contact the patient by phone, by messaging, by certified letter. All of those things take time. Referral processing was a significant time waster, we felt, in these practices, calling patients back for results and calling other physicians to obtain notes from referral visits as well. So a process redesign that was implemented at Fairview included having the MA conduct a pre-visit call. And the medical assistant during that pre-visit phone call would set the agenda for the visit 1 to 2 days before the actual visit. So asking the patient to describe what is it that the patient wanted to see addressed during the upcoming visit. They also did other screenings such as depression screening over the phone, and pre-populated the note and did some patient's advanced directive determination as well. At Mayo Red Cedar, they do pre-visit labs, and we do pre-visit labs at my organization now as well. So labs are ordered to be done either on the day of, the morning of a visit, or the day before a visit. So you ask your patients not to come in between visits, but rather prior to the next visit. At Theta Care, they do same-day visit labs, so a lot of point-of-care testing that's done there, and sent immediately off to be tested and returned so that the results are available to the care team during that visit and can be discussed. And in fact, that's how, as a patient, I want to have a discussion with my doctor about the results of whatever testing took place. So what we found at MGH, and this is Dr. Crocker and his group, is that pre-visit labs decreased phone calls by 89%, decreased letters to the patient by 85%, decreased additional visits that were being requested and scheduled simply to follow up on labs by 61%, and also decreased the total number of tests ordered. Patient satisfaction rose, and there was a savings per visit as well. Annual prescription renewals can save a patient time as well as save a physician time. So about half an hour a day if you provide annual prescriptions. Now I understand that not all of the prescriptions that we write for our patients are stable. We're actively managing several, and in those cases you may not be able to implement this. But when it is an option, writing for a 90-day prescription with 4 refills, not 3, but 4 refills to allow ample time for their next annual visit to you is an important time saver for you. So inadequate support to meet the patient care demands for your team. And if you share your work with your team with greater ratios of MAs or nurses to physicians, implement longer and more significant rooming protocols, again, so that your MA is not just checking a blood pressure or weight and putting that patient in your room, but instead, maybe checking the blood pressure, checking the weight, of course, doing the implementing, using standing orders to do immunizations, using standing orders to order screening tests based on what's age appropriate. All of that stuff can be done even in the pre-rooming. Okay. Back to Mayo Red Cedar, they use a model of nursing that's actually 2-to-1. And I want us to embrace for a second that we need to think about our model of patient care a little bit different. So right now, everything comes to the doctor, right? Everything comes to the doctor, and then the doctor decides, do I need help with this, or can I do it myself? Now, I will remind you that the doctor is the most expensive person in that equation. So when the doctor, in this instance, is the triage person for the work that needs to be done for that patient's care. You are used to being, Superman, right? We do it all, one-stop shop. But if we redistribute our work more strategically, so instead of sending all the work to the most highly trained person to then distribute, if you think about who else can look at that inbox or look at the faxes, different practices utilize these strategies differently, but who can work with that before it reaches the doctor? And so we basically need a triage person for our practice in the same kind of way that we use a triage individual in the room. Okay? In the interest of time, I'm going to go through these next few slides fairly quickly because we're restating some more examples on the points that were already made. When a doctor does it all, he can see 1,000 patients and feel burned out. When we use help, we can see more patients. We can feel satisfied and get joy in our work as well. More supply. And we can yield and actually satisfy the demands of a larger group of patients. Assistant order entry is used at University of Alabama. What was found in this setting was that productivity was increased by 16%. Notes were completed in clinic now 43% of the time, as opposed to never before using team-based documentation, and there was a marked reduction in work. I want to talk just briefly about the inbox, right? The inbox, the inbox. Everything comes down to the doctor. Lots of things that we don't need to see now come to the doctor. So the electronic health record is now finding the one person or the one source that everything reaches, and it's the physician, which is very different than the way that information used to be communicated before the EHR. So much of what is coming into our inboxes is not urgent. They're not even test results. It's a lot of other stuff that we're seeing. And we're spending a significant amount of time per day just managing our inbox. At Fairview, a nurse filters the inbox. Okay, so she will filter out and acknowledge all of the normal lab results. Will filter out other notifications that the doctor just doesn't need to see. And will leave only the abnormal or urgent physician-related inbox messages for the doctors. So at that same institution, this is what Dr. Jerzak said. So instead of 7 p.m. with computer work at home, it's 5:30 yoga with deep meditation. So more comments and reflections. At UCLA, it saves 3 hours per day, which is team documentation. Increase in patient satisfaction. Again, I'm just showing you various examples of the same thing that are utilized in slightly different ways in different practices, but all yielding increased patient satisfaction, increased quality metrics, and increased provider satisfaction as well.
A lot of these principles lend themselves to hospital work, but all of the examples are pretty much outpatient care. Is there a comparable literature for hospital work in terms of?
Thank you. Yeah. So you're right. This study was done of primary care practices. And so this was really based in the office setting. It's interesting because I had a question earlier about looking at burnout within hospitalists. And a colleague of mine at Cook County, Keiki Hanami, is working with the Society of Hospital Medicine to do a much more comprehensive look at burnout among hospitalists. That's different. I'm not sure of the literature around subspecialty consultative practice in the hospital. If you're asking about it, we're going to be learning a lot more about hospital medicine in the near future. RFID technology, I spend a lot of time just getting into the patient record. So I have to sign in to the computer, and then I have to sign in to Citrix, and then I have to sign in to PowerChart, and then I have to put in my patient's information. So you get the point. It can save a lot of time per year. I'm throwing it up there. I know that some of you may not have the capacity to implement that in your smaller practices, but as an organization, it's a good option. Teams that function poorly is the last challenge that I'm going to talk about here. Teams that create more work for you as a physician is something that you need to address. And there are several ways that you can do that. Some strategies include co-location. So in many practices, as well as hospitals, nurses and doctors are separated. They have separate workrooms, separate work areas, bringing them together so that communication is not just a series of pings back and forth, but rather communication can be done face to face is incredibly effective for several of these practices, so that there's line of sight, so that when something comes up, the nurse can immediately bring it to the physician rather than, again, inbox messaging back and forth all day. Another action step is making time for huddles and making time for team meetings. So daily huddles are used at South Huntington and in a variety of our practices. All PCMH practices implement huddles, and I cannot say more about the utility of just starting your day briefly with your colleagues, your team, to be able to plan out what that day is going to look like. If you're not using team huddles right now in your practice, you absolutely should try that. I'm going to just refer you to the AMA website. Our Steps Forward has a set of offerings, materials that you can access. You do not need to be an AMA member in order to have access to these resources. Just look for them. It's really a wealth of information. We have a number of toolkits that are available to you online. So if there's anything here that I mentioned today that you would like to take home and start in your own practices, please visit the website. You'll see resources that explain how to implement that, different checklists that can be used, and a variety of other elements in our toolkit. We also have resources in these other areas which are outside the scope today. To give you an example, 10 Steps to Pre-Visit Planning outlines the responsibilities during the visit, but also before and after the visit, including the case of using huddles. Visit prep checklists that can be used by your MA as they're rooming the patient, if you choose to do this on paper. As well as online calculators. So getting to that business issue, how do we rationalize the cost? This will allow you to put in some of the numbers that are pertinent to you to give you an idea of what is going to be the cost of bringing in more help and what savings may you expect from that. There's also a burnout survey online there if you are interested. Happy to talk to you more directly about it. We have a consultant directory that's listed there that will allow you as well to access additional resources if you'd like to bring someone into practice. Well, thank you for this privilege, and I think we probably have time for some conversation.